Hi, this is Dr. Akhtar, and today the topic is EVS versus CEVE study. EVS means endophthalmitis vitrectomy study, and CEVE means complete and early vitrectomy for endophthalmitis after cataract surgery, an alternative treatment paradigm. So, in this study, we report the treatment outcome of complete and early vitrectomy for endophthalmitis, also known as CEVE, after cataract surgery, as the predominant initial treatment. Acute post-cataract endophthalmitis. It is one of the most feared complications of cataract surgery, and it causes significant morbidity, and almost half of the patient lose reading visual acuity, which is more than 20/40, and a quarter becomes legally blind, which is 20/200 or worse. In the endophthalmitis vitrectomy study of 1995. So this EVS study was done in 1995. As the only prospective randomized study for the treatment of acute post-operative post-cataract endophthalmitis. The EVS study, it established that the core vitrectomy is as equivalent to tape and inject of intravitreal antibiotic. So according to EVS, core vitrectomy is equivalent to tape and inject. For the 75% of eyes that presented with hand motion or better vision, the EVS also found no benefit from the use of intravenous antibiotics. So these two findings encouraged office treatment of endophthalmitis with substantial cost saving and increased convenience. But today, vitrectomy has become small gauge and sutureless, employing increasingly precise suction control and ultra high speed cutting rate of 10,000 cuts per minute compared to the 600 cut per minute available in the EVS era. Improved microscope with panoramic viewing and have also significantly enhanced the safety and efficiency of surgery. Despite these improvements, visual outcome of post-cataract endophthalmitis remains mostly unchanged or have even deteriorated since the EVS, with more than 20/40 visual acuity achieved in half of all cases at best in virtually all studies that have reported on the treatment of endophthalmitis. So this situation is partly explained by the fact that the majority of these endophthalmitis eyes are still treated with tape based in the according to the EVS recommendations, and do not benefit from the extensive surgical advances made over the last 2 decades. In fact, some experts have questioned the applicability of this EVS study to today's treatments. The main limitation of the EVS is that its vitrectomy was strictly a core vitrectomy. So this core vitrectomy was strictly core vitrectomy and the removal of cortical vitreous and the removal of purulence on the retinal surface explicitly discouraged in the EVS study because of the fear of the causing iatrogenic retinal tears. The primary goal of this partial vitrectomy in the EVS study was to obtain specimens for culture and inject intravitreal antibiotics, and removal of infectious material was a secondary goal. But nowadays, instrumentation allows the performance of complete vitrectomy without compromising safety. The main advantage of a complete vitrectomy over a core vitrectomy is the removal of purulence in the cortical vitreous and on the retinal surface, and where the most of the visually significant damage from endophthalmitis likely occurs. In fact, the major cause of vision loss in the EVS study was maculopathy, accounting for close to half of the cases with impaired final visual acuity. of less than 20 by 40. Therefore, in an effort to limit retinal injury caused by endophthalmitis, retinopathy, endophthalmitis maculopathy, we prefer to perform complete and early vitrectomy for endophthalmitis, also known as CEVE, for all fundus obscuring infections. So, for all fundus obscuring infections, CEVE is recommended. TAPE is reserved for early cases in which a view of the fundus is relatively preserved. Regardless of initial treatment, we follow patients closely with a low threshold to retreat significant deterioration of intraocular media clarity. CEVE treated eyes with deteriorating clarity receive additional vitrectomy, lavage, and or antibiotic injection. This is known as CEVE Plus. In this study, we describe the characteristic and outcome of 62 endophthalmitis eyes treated with such an approach in the modern era of small gauge vitrectomy. Patients and methods. Patients. The study include a review of clinical features and microbial factors in all patients treated for acute post-cataract endophthalmitis between 2007 and 2017 at retina specialists of Alabama, Birmingham. Endophthalmitis was defined by the appearance of clinical symptoms and signs of endophthalmitis within 3 weeks of cataract surgery, regardless of whether or not culture was ultimately positive. Cases that had cataract surgery combined with other ocular surgeries were excluded, as were cases that were deemed to be sterile post-operative inflammation. Since our goal was to assess the ability of predominantly CEVE treatment to restore good visual acuity like the EVS, we exclude eyes with pre-existing maculopathy or other comorbidities limiting visual acuity to less than 20 by 100, and eyes with severe corneal opacification precluding even core vitrectomy. Initial treatment: patient with light perception presenting visual acuity were counseled that core vitrectomy was the preferred treatment. For hand motion or better visual acuity, patients were counseled that either TAPE or core vitrectomy were reasonable options, but that we preferred vitrectomy for fundus obscuring endophthalmitis. Patients subsequently gave informed consent prior to all treatments. As a result, CEVE was usually performed for anything but early endophthalmitis. Early endophthalmitis is defined by a preserved red reflex and a posterior view adequate to rule out retinal distress, particularly in the macula, hemorrhages, vasculitis, retinal surface purulence. In such early endophthalmitis, TAPE was typically recommended, and culture were obtained by needle aspiration of the vitreous or anterior chamber. Vitrectomy was predominantly 25 gauge with occasional use of 23 gauge or 27 gauge vitrectomy. The primary goal of CEVE was to remove as much purulence as safely as possible, particularly from the surface of the macular hypopyon. If needed, CEVE included the creation of a posterior vitreous detachment or debridement of macular surface purulence. As the initial intravitreal treatment, 100% of patients received vancomycin 1 mg, 95% of patients received ceftazidime 2.25 mg, 31% of patients received dexamethasone 0.4 mg. At the conclusion of vitrectomy, and one patient received amikacin 0.4 mg. At the conclusion of vitrectomy, 18% of eyes received 0.75 microgram of TPA intravitreal for fibrinolysis to aid removal of macular hypopyon. Patients were admitted as inpatients typically for 48 to 72 hours in all cases of CEVE and in 9 of 14 TAPE cases. Most patients received frequent topical treatment with fortified vancomycin, tobramycin, and prednisolone acetate while avoiding the supine position. Systemic moxifloxacin or vancomycin was given in most cases to achieve protective retinal and uveal tissue level against gram-positive bacteria, which were 94% of all cultured bacteria in the EVS, aided by the expected breakdown of the blood-ocular barrier. Inpatients were typically examined twice daily, with the patient held NPO pending each examination result. Retreatment. Both the decision to retreat and the form of retreatment were determined by the severity of retinopathy uncovered at the initial vitrectomy, gram stains and cultures, and the ability of an eye to maintain or improve the media clarity noted at presentation are established by the initial vitrectomy. Recurrent or increasing media opacity despite treatment was viewed as an indicator that inflammation or infection were inadequately controlled, and the eye was retreated accordingly with vitrectomy or tape. Antibiotic instilled during subsequent treatment were within safe doses and tailored to available culture results and clinical suspicions. Visual outcome analysis. Final visual acuities were measured using Snellen charts with a minimum of 3 months follow-up required unless visual acuity of 20 by 40 was achieved earlier or irreversible vision loss was deemed to have occurred. A Pearson chi-square test with 1 degree of freedom was used to compare success rates in achieving 20 by 40 visual acuity across different groups within this study and between this study and in the EVS. Results. 69 eyes of 69 consecutive patients were identified that fulfill the criteria for APCE as defined above. Similarly to the EVS, a total of 7 eyes were excluded, one based on severe corneal opacification precluding even core vitrectomy, bacillus vesical outcome. 2 were excluded due to lack of sufficient follow-up, 4 based on pre-existing visual acuity limiting ocular comorbidity. So, initial treatment was with ACE complete vitrectomy as possible in 77% of cases and with tape in 23% of cases. Of the 62 eyes, 89% required at least one vitrectomy, including 7 out of 14 eyes initially treated with tape, and 61% needed at least 2 treatments, 9% in the EVS. So as compared to EVS, it was 9%, in this study it was 61%. First cultural results were more likely to be positive in PL vision and hand movement eyes, which were 90%, compared to counting finger or better eyes, in which there were 43%. Final visual acuities of all eyes. Of the 62 eyes, 79% achieved final visual acuity of more than 20 by 40. Those who presented early in the EVS, it was 53%. So this is much better than EVS. Those who presented early, less than 5 days after cataract surgery, had better outcome than those who presented later, more than 5 days, with 90% in the early group achieving more than 20 by 40 visual acuity compared to 68% in the late group. Profound vision loss of less than 5 by 200 occurred in 26% of eyes with virulent growth. 16% of the in 26% profound visual loss occurs. They have virulent growth. In 16% of late presenters of more than 5 days, and 11% of eyes with initial LP vision, profound visual loss occur. So violence was hence the strongest predictor of profound visual loss, followed by delay in presentation and LP visual acuity on presentation. Vision loss of less than 20/40 occur in 13 eyes, which were 21%. The main reason was maculopathy in 6 eyes, retinal detachment in 4 eyes, and phthisis in 5%. Maculopathy mainly include foveal atrophy and chronic macular edema, but also epimacular proliferation, and one TAP-treated case of residual vitreomacular attraction, for which the patient declined treatment accepting 20/50 visual acuity. So this study is the first detailed report of improved visual outcome for acute post-cataract endophthalmitis since the EVS 25 years ago. Akin to treating infections elsewhere in the body with abscess drainage, we currently watch in sustained antibiotic dosing. We believe that CEVE and CEVE Plus rapidly restore and maintains a sterile, non-toxic intraocular environment, limiting further damage to the retina and uveal tract. We recommend CEVE as the primary treatment for all fundus obscuring acute post-cataract endophthalmitis, which consists of 75% of the cases, which includes all LP and HM eyes and approximately half of eyes with CF or better visual acuity. We reserve TAP for CF or better eyes in which the fundus view is adequate to rule out macular distress.